on, let me sit down. All right.
Hello, I'm Dr. Rich Lee. I'm a family physician who's been in practice for 30 years. The usual things of treating disease or preventing it, but the greatest thrill of my practice, the greatest reward, are improving health, doing whatever I can do to not only keep people from getting out of trouble, but finding all those little nuances in their life that we can solve to actually help them feel better, to physiologically and mentally be younger and more vibrant. And it's wonderful to see the results of that in my patients and now finally myself. But one of my poster people for this is Daniela Dine.
Hi, I'm Daniela Day-Forrest. I am a functional diagnostic health coach. I am the author of Own Your Wellness. And like Dr. Lee, I spend most of my day helping my clients get to the root of why they're not feeling their best and get them onto a path, a consistent path of moving forward and feeling the best they've ever felt in their lives. That's why I wake up every morning.
Okay, so a topic that's coming up more and more now and has been controversial, and I think the controversy is finally being laid to rest, is the whole issue of hormones. Now, the sad truth is we are all outliving our gonads, meaning beyond 1,000 years ago.
It's true.
Yeah, at 68, 1,000 years ago, I would have been dead probably 20 years ago, and so as we go beyond that age of, quote, reproductive fertility, what's happening with our bodies and ourselves and our lives? Now, another sad truth is life is not fair, especially for women, because they are much more dependent upon estrogen and progesterone and even testosterone to keep not only the whole reproductive cycle going, but to keep the whole body and mind together and running.
And it's not our mother's menopause. I mean, or my grandmother's, like, at 47 years old, I mean, obviously my reproductive years are done for the most part, but I feel like I'm 10 years younger than I am, maybe more.
Well, you look 20 years younger at least. So,
Thank you. But you know, like it used to be, I mean, I remember these over the hill parties that my parents used to throw, right? It was a big deal when you turned 40, you were like done. You were becoming an old person. In no planet do I feel like I'm in that same category, you know? And so, like you said, our physiology is way outgrowing what our reproductive organs are designed to do. So, you know, I think that hormone replacement therapy can really enhance this process and ease this transition for so many people. And it makes me sad. Like my mother's generation, my mother's very young. She's only 21 years older than me. You know, the amount of hysterectomies that were happening was nonstop. It was almost everyone she knows, herself included. And the option for hormone replacement was zero. So they all suffered through menopause. And the incidence of cardiovascular disease goes up, of osteoporosis, not to mention like the brain fog and, you know, just these horrible symptoms that not necessarily need to be dealt with if you have the right guidance and hormone replacement.
Right. Now, again, there was a lot of controversy, and this centered around what was called the Women's Health Initiative. This is a study where they looked at synthetic hormones given to women 65 and older. It was a synthetic estrogen. Well, it was derived from, it was called Premarin, which meant pregnant mare urine. It came from horse pee, for God's sake, in combination with a synthetic progesterone. It was given to these women, and it's no wonder that it didn't work as well because it didn't match what their bodies were producing. The estrogens had the, quote, minimal amount of the good ones, the estradiol, and a lot of the bad ones, which are actually more promoting of cancer, other reproductive dysfunction, even premenopausally. And then the progesterone itself was synthetic, and it messed up blood sugar.
Progesterone, the Premarin, wasn't it worse as far as the ensuing outcomes than the estrogen?
Yeah, this is why they said HRT is bad. And they weren't looking at how they were giving it. They weren't matching it to what your body produced.
Right.
And thank God, or thank wisdom, that now large medical expert groups like the American College of Obstetrics and Gynecology are now saying that estradiol, which is the most pure, healthy form your body produces, given externally to postmenopausal women will improve their health. In fact, it'll even do it safely for women who have been treated for breast cancer successfully, women even with estrogen receptor positive breast cancer. So that whole argument is finally switching over to, let's get you back to where you were physiologically 20 years prior without increasing the risk.
Right. Oh, it's just, I just can't, and I went on hormone replacement earlier than the average Jane,
right,
because I have osteoporosis. And I found out about it at a very young age, thank goodness. And Dr. Lee put me on hormone replacement because my estrogen levels were in the postmenopausal range when I was 40 years old.
Yeah.
I mean, just at the bottom.
Yeah.
So I have enjoyed the benefits of keeping my vitality and my youth. If anything, I feel better than ever.
Yeah.
And I can't tell you how many times I would go to my specialist, OBGYN or whatever, for my workups, and they'd be like, why are you on this? And it was just
because it works.
Yeah, who's putting you on this? My doctor. Yeah. In fact, when my OBGYN for many years finally quit or retired, I had to find somebody new, and I found this woman who I thought was more functional health minded. Yeah. So I went in there, even though I'm on hormone replacement, I still have some perimenopausal symptoms. Yeah, I get hot flashes. I had one beautiful one this morning. It was amazing. And, other symptoms. And so I went in there, I brought for her my Dutch test, and maybe we could talk a little bit about Dutch testing in a little bit, but it explains basically not just what are your hormone levels, but what is your body doing with
exactly.
And I showed her this test. She wouldn't look at it. And she says to
she doesn't want to know why.
She says to me, I only do science-based medicine in this practice, and that is not science-based. And I'm like, okay.
Did she read the papers? No.
Oh, no, it gets better. So then at the end of our conversation, she said, I might suggest that we put you on a low-dose antidepressant. And I said, well, why would I do that? I'm clearly not depressed. Yeah. And she says, well, anecdotally, a lot of my patients feel a lot better with their hot flashes and other symptoms when they go on an antidepressant. So out goes that science-based medicine immediately.
Yeah.
Needless to say, I didn't go back to that practice.
It's tough because a lot of OBGYNs are part of medical groups where they're being forced more and more to only apply the standard of care. Do not deviate from it. Do no more and no less. But the standard of care has not been upgraded to the newer evidence that this is actually safe if it's done right. Some are, if they're going to prescribe anything, they're still god-awful prescribing Prempro or Premarin.
Or birth control pills to 50-year-old women. Right. Twice now I've had that suggested to me, and I'm like, wait a minute, I'm on hormone replacement to save my bones. Why would I take, and maybe we should talk just a little bit about how birth control works. Right? Because it's such a low dose. That it actually, so when you take a hormone from outside of yourself, exogenously, your body basically shuts down its own production of that hormone. I'm
not going to make any more.
Because why waste the resources, right?
Exactly.
So it suppresses your hormone levels to such a point that not only are you not interested in sex, but your chances of getting pregnant are almost zero.
Right.
And then they're suggesting this to women in my age group.
Right. But that is hormone replacement.
Right.
And it's an oral form.
Which, by the way, can we talk about oral estrogen?
Yes.
You want to tell me what you think about that?
Well, the problem is if it's oral estrogens is what they usually give you, which is a mishmash of different forms of estrogen. It goes into your digestive, it goes through your liver, and your liver starts metabolizing into different forms, both good and bad, depending on reactions in the liver that we don't control that well. We can. And so you end up with the good ones and the bad ones, and not in the levels that you would need to mimic what your body did when you were of reproductive age and your own hormones were working really good.
Yeah. Okay. So when you prescribe hormone replacement to women my age and older, what are the forms of estrogen and progesterone? And do you always put them in combination? Like, Can we talk
Not
a little
always.
about that?
Now, number one is estrogen. That's the one hormone. It's the feel-good hormone, and specifically estradiol, which is what we call the E2 or good estrogen. This is one that has more and more evidence that not only helps improve health, but reduces cancer risk. It does not promote breast cancer or other forms of cancer. It may be chemoprotective against that. And the forms that I use are delivered through the skin transdermally. So they don't go through your digestive systems. They're not modified by the liver. The liver doesn't have to deal with, oh God, more hormones. I have to metabolize those out. And it's dosed according to actual levels and secondarily symptoms. It's whatever works.
Right.
It's nuanced. It's difficult to overdose on them. Our biggest mistake is underdosing. But the idea is you just give the body through the skin with no modification what it uses in estradiol. Now, a lot of OBGYNs are also told, or the standard of care is, do never give an unopposed estrogen. Now, again, that was giving people oral estrogens and oral progesterone, or not, without progesterone, and it was the wrong type, so you ended up with the good and bad ones. Unopposed estrogen can theoretically increase growth of the lining of the uterus and actually promote cancer of the lining of the uterus. In 30 years of practice, I've never seen that from any estrogen-type therapy. In fact, the only case that I remember in the last 10 years was someone who wasn't on any HRT, and thank God we caught it in time. So,
well, I will say, in my experience, because when we first started HRT with me, when it came to estrogen, I was not taking progesterone at the beginning. And I think because my personal history, I always had very low estrogen levels to begin with. I felt estrogen dominance, because I didn't have enough progesterone that I was making on my own. And so when we put in the progesterone, I felt much more balanced. And recently I've decreased my dose of estrogen because I was getting some of that estrogen dominance, a lot of PMS symptoms and stuff like that. And since we've brought that down a little bit, keeping the progesterone where it was, I feel much more balanced. So to your point, it's every person's chemistry is so different. And I really appreciate that you take into account how somebody's feeling, and I think like supplements, like prescriptions of all kinds, so many of my clients don't really appreciate how powerful these chemicals are that we are taking in. And, they affect the way you think, they affect your moods, they affect your physiology, of course. And some people are a little bit more numb to how their bodies feel. But honestly, most of the women I work with, myself included, very sensitive to small changes like that. And I really appreciate, just taking a moment, seeing how you're doing at this new dose, checking in before we make further adjustments.
So don't get me wrong, progesterone is not evil. Many women do appreciate a balance of it. And we have forms now, either transdermal or there's an oral form that does not get messed up. It's called Prometrium, and I haven't seen any issues with that. Some women need a whole lot of progesterone, and that helps with primarily sleep and to some other degree energy. Now, progesterone, all hormones come from LDL cholesterol, and LDL is considered to be evil. We're trying to lower it down to practically zero. Well, that may be good for some people's hearts who are high risk, but then you're choking off the entire supply of all your hormones downstream. LDL cholesterol goes to another hormone called pregnenolone, and the body will decide if it's going to put that into sex hormones or into stress hormones. But in that pathway, progesterone is its own reproductive sex hormone, but it's also the supply of cortisol, which is your main stress adaptation hormone. So you have to understand, for women who are under higher stress, having the right amount of progesterone will help supply both the reproductive side of it, but also the cortisol stress adaptation side. And I think you had issues with that.
A little bit. Yeah, I had a little bit of that. Not anymore. I want to go back to, because I don't want to gloss over what you said there about cholesterol.
Yes.
And I mean, we could do 2 hours on just that one conversation. So we'll try to touch on it shortly. But, obviously there's so much confusing, just like hormones, confusing information out there. And, a lot of the people I work with who are my age and older, are a little bit stuck in the 1989 dogma of
Or
low
earlier.
fat, low calorie, you know, and the reality is, if you're not eating whole foods and supplying yourself with the things that you need to produce the right amount of cholesterol, then you won't have any energy. You won't have any hormones. You won't have cortisol to deal with stress. You won't have any resiliency. That said, the other, you know, and people believe that eating cholesterol is going to increase their cholesterol significantly. Right. I will tell you, recently I had some blood work done and my cholesterol was as low as it's ever been. I think my total was like 140.
Which don't get too
and
much
I said, Dr. Lee, I want more cholesterol. How come my cholesterol is so low? He goes, Daniela, you know how to increase that. You need to eat more sugar.
Which, more
That's
carbs.
what you told me.
I know, more carbs. Well,
more carbs. And because I don't eat a ton of carbs because it makes my head go crazy.
Right.
And so if you think about that, if I wanted lower cholesterol, what might I do?
Eat pork. More fats.
And exercise.
More fats.
Eat healthier fats.
We screwed it up so badly 20, 30, 40 years ago. We found that heart disease in the Framingham study was related to elevated LDL cholesterol. Well, it wasn't just the LDL itself, it was how bad that LDL was.
What were those particles
So
like?
LDL, when it's oxidized, becomes a sticky tar ball. When it's unoxidized, it becomes a fluffy tumbleweed. Tumbleweeds don't stick to anything, tar balls do. So whatever you can do to reduce the oxidation of your LDL cholesterol, that's mainly a diet that's colorful, that's full of more antioxidants, it's going to not only lower the LDL appropriately, but have less dangerous ones. Now, we also thought that we put people on low-fat diets. We put them on margarine, for God's sake. We put them on lousy carbs to keep them away from fat. And all of a sudden, they started developing diabetes, and their LDL didn't get any better. So we said, oh my God, we have to develop a drug to correct it because the low-fat white carb diet isn't working.
We literally created the problem.
We created it. So there are good fats, there are bad fats. And more good fats generally will bring the LDL down, even though we thought for decades that foods that had fat were worse for you.
I wish we had a different word. I mean, I know we could use the term lipids, or whatever, but I really wish we didn't use the word fat when it came to food. To translate to what's on our hips and
essential
bellies.
Fatty acids is what we're talking about. And these are the ones that actually do help. First of all, your brain is made of fat, and the right type will help keep those. It runs on sugar, but it's made on fat. Not enough fat in your diet, or too little, your brain's going to degrade more rapidly. They're, like I said, essential fatty acids. I mean, your body can't live without them. Some neurotransmitters come from that. They get converted to whatever other sources of energy your body needs, including hormones. So
right. And going back to our hormone conversation, can we touch a little bit on what I still think is a little bit taboo when it comes to women's health and hormone replacement, and that is testosterone.
Mr. T, I pity the fool.
Mr. T.
So women and men both have testosterone. In fact, all of our hormones, again, I mentioned pregnenolone, it goes to something else called DHEA, then it goes to testosterone in both men and women. Women convert it more rapidly into the estrogens. Testosterone, whether you're male or female, has several benefits. Better physical energy, better exercise recovery, better bone density, better red blood cells, better HDL cholesterol, less tendency to have high blood sugar, so lower what they call hemoglobin A1C, preventing dementia down the road, and better lean body mass, and in men, less depression, and of course, being sexy is number 11. Everyone thinks it's number 1. Okay, but no, there's so many other things that having the right level of testosterone, not super physiologic, and most people are too damn low. Why is that?
Men and women.
Yes. Oh yeah.
Yeah, and I would say, I can see, I get this client, I'm sitting there talking to them, and it's that woman who's usually a little bit slight, very anxious, very moody, and I look at her and I go, you need testosterone. Like I could just see it, and it really seems to it really seems to sort of smooth out particular anxiety. But obviously there's so many benefits for it. In fact, I'm getting back on it myself. And part of the reason is because we brought the estrogen down a little bit. I need to make sure I'm getting the right amount of hormones to help my bones stay as strong as possible.
Yeah.
Because I keep putting it on and it's good. I want to keep it that way. But, I really do see it as an amazing mood stabilizer and confidence builder for so many women.
Well, men too. In fact, if you're in a differential diagnosis for a man with depression, you have to check testosterone levels, vitamin D levels, B12 levels. But one of the most common causes of depression in men that's refractory to antidepressants is low testosterone.
Yeah.
Now, why is it so low? Well, when our body's under stress, it steals from our sex hormones to make stress hormones. Our diets are pretty bad. And then let's not delve too deep now into the subject of xenohormones, things in the food chain, in the plastics, in the air, in the water that are messing up our hormone regulation.
But to keep it even more simple than that, wouldn't you argue a lot of men's testosterone is low because their adiposity, they're too fat. They're carrying, and fat is its own organ, and it creates what?
Estrogen. From the testosterone.
Right. And so the more estrogen you have as a man, the lower your testosterone will be,
That's where your man boobs come from.
That's exactly right. And I'll tell you what's even more upsetting than that is watching children. When I was a kid, nobody was overweight.
Yeah.
I mean, there was like the one kid, and you still remember their name, right? Like it was like, because it was such an anomaly.
Yeah.
But little girls are starting puberty so much earlier now because they're overweight. Right.
Yeah.
So they're having estrogens much sooner.
Right.
Not to mention what's in our environment.
Yes.
And little boys are having later puberty.
Right.
Again, because they're not getting outside and exercising, and they have too much adipose tissue.
Yeah, they're sitting at the computer, gaming away, eating junk food, or on social media on the computer.
Yeah.
And just it's not
right. So it's messing up our hormones at the front end of things, and also on the back end of things when we enter menopause or andropause or wherever we are in life.
Right. She hates it when I do this. I'm bragging here. This is the poster child for women testosterone. This is my wife. In this picture, she's 72 years old. She was put on transdermal testosterone by her oncologist after completing her aggressive treatment for breast cancer 29 years ago. That's probably been her salvation. Is she
still on it?
Oh, hell yeah. Yeah.
Because that's another question I have for you is women either getting on HRT later in life or staying on HRT. And by later in life, I mean after 65.
Right. Well, often a lot of the regular, organizations that determine what you should do for health promotion and whatnot will say after 65, all bets are off. You're going to be dead in 6 years. You don't even have to bother anymore. Well, no. No, she's been on it for all that time, has not had any cancer recurrence.
Brilliant.
She started mountain bike racing at age 62 and made #1 in the nation at 65 in cross-country mountain bike racing. She's as sharp and sexy as she was 20 years ago.
Wonderful.
So, yeah.
So do you have a lot of women that just stay on it once you get them on it?
Yes.
And then at what point do they ever get off of it?
They don't want to.
I see. But
I don't see a reason why if they're going to live beyond their reproductive age when their ovaries are gone and they want to keep the same level of quote anabolic status, meaning building up and repairing of the body tissues, the brain, everything from the brain all the way to the toes, then it would make sense, at least so far in the 25 or 30 years I've been doing this, to keep it going. Not one of my women on appropriate HRT has developed any cancer associated with that.
Have you ever, and I'm asking because I'm curious about like my mom, have you ever put a woman on HRT after the age of 65?
Oh, yeah.
Really?
Yeah.
Okay.
Yeah.
Interesting.
They've asked for it. I have a woman, she's 96, and she asked me 2 weeks ago, and what about sex? We're going to have that discussion.
I'm sorry.
And she is younger looking and very well kept. So
that's great.
Yeah.
That just makes me happy. And I'm so thrilled that it's finally being vindicated, the concept of HRT for so many women. The reality is, I don't know why women in menopause, actually, let me take this back. Women in general, women's health is so vastly different than men's. Our physiology is so much more complicated. And I realize that's why most studies aren't done on us.
Right,
because,
yeah.
Because it's too tricky.
Exactly.
But the reality is we are half the population. By some measures, measures more.
Yeah.
And we control the purse strings for most things, whether it's for our children and our parents and our husbands and ourselves. I think this is a really exciting time to finally see research being done for us and to help us feel better and realizing how vastly different we are.
The problem is you have to get the world out there to listen and understand the research.
Yeah.
You've still got, like I said, you have OBGYNs who have access to all information, but either they're not asking why anymore. But I can tell you that most of the women OBGYNs after menopause are on something.
That's correct.
Now, not every woman suffers through menopause. Some, it's no big deal. They just seem to cruise through life, and I don't know what that is in all those cases or why. Actually, I knew on some of them, they remain sexually active.
Oh, it makes a big difference.
And with even out HRT, that keeps the whole feedback loops going. That helps. Of course, that involves having a partner who's worth being active with.
Yeah.
Which is a separate topic of frustration, I'm sure.
Can we talk I want to touch a little bit more on some of this HRT being offered to people, because not all of them are as well versed as you are in what you're doing and the nuances of these prescriptions. And in particular, I'd be curious to hear your thoughts about pellet therapy.
Okay.
I have my opinion of that, and I have some interesting stories to tell about clients who've been through it. So I'd be curious to hear what your thoughts are.
Okay. I don't do it, not because I'm totally against it, but my issues with it is one, you have a fixed amount of hormones. They're implanted through a little tube that uses your osmotic pressure to drive the hormones out at a steady state.
And it's not there. They put it
right
in
your butt. Okay, yeah. All right, so yeah, they put it in your butt. That's for the pain pellet therapy. So
yeah.
And one problem is if that butt's in a hot tub, it's going to accelerate the release of that hormone. So you're either going to get a surge of it there, or it's going to be used up beforehand. It's convenient. You just sort of set it and forget it. For some people, it's a pain in the ass, literally. If it's the wrong hormone ratio, then you're kind of
stuck with it.
Yeah, you're stuck. It's a good money maker for doctors who do that, and it's a good sort of no-brainer for people who just don't want to bother putting on a gel once a day or a cream about the size of a pea.
Yeah.
In some people it works if it's just the right dosage, and more power to them. But those are my reservations about it.
Yeah. I think my biggest issue, having several clients who've used it over the years, is it's kind of like when you're sucking on a Tic Tac,
Yeah.
And you get that there's like a lot of surface area at the beginning, you're getting a lot of flavor, and then by the time you get to the little middle,
nothing there.
If you haven't chewed it already, there's nothing there.
Yeah.
And so you kind of get this bolstering at the beginning, and then it peters out to next to nothing before you get the next pellet inserted.
It should be what's first order. I mean, day one is the same rate as day two. That's in theory.
I think that's more theoretical.
Yeah. I have friends who worked in startup companies who were doing that for pain relief medications, and they found it wasn't first order, which is why the companies failed. But the consequence of that is far worse. Here, it's not going to kill you if you get too much or too little, but it may not be optimal.
Yeah. Okay.
If it works for you, fine. It's not something I do.
Yeah. Okay, so let's kind of wrap this conversation up with figuring out, it's one thing to get on hormone replacement or to even consider it, but it's really important that you figure out, what is your body doing with these hormones?
Yeah.
What are the ratios of these hormones? And when you're doing a blood test, which is fine because it does give you ultimate levels of these things, but it only gives you that moment in time, And so my favorite test I run on almost all of my clients is the Dutch test.
Yes.
And it stands for Dried Urine Test for Comprehensive Hormones. And what it does is not only does it tell me about what their testosterone levels are, their progesterone levels are, cortisol, melatonin, DHEA, but what is your body doing with this? And so there are, it shows you a graph of these 3 different estrogens.
Right.
What are the pathways of detoxification that it's going down? So if I see somebody who's not detoxifying not methylating and excreting their estrogens well already, and then we pile on more, we're going to end up in a potentially carcinogenic place.
Correct.
Yes?
Correct. So it is a wonderful test, and it is accurate. For years we test pregnancy tests as urine tests, for God's sake. Anti-doping tests for athletes are urine tests. Hormones excrete in very reliable concentrations in the urine, usually on a steady state, but there are circadian cycles too, particularly cortisol, which is a major stress hormone. That's a real benefit of this test. It shows you where those cortisol levels are throughout the day. They should be high in the morning, they should be down in the evening. And a lot of people, it's too low in the morning, too high in the evening. They're in the opposite of where they
They're
should
not sleeping, their blood sugar is a disaster,
So it's a great test. What is it, $200 these days?
Oh, it's like $450.
Oh, we're not. Okay, still.
Yeah.
If you had to pay for those hormone levels in a blood test, it'd be several $1,000s. So it is reliable, it is accurate. I think it's a great test. It takes some explaining to show someone. You talk about estrogen metabolism and the fact that, again, there are good estrogens and bad estrogens. Estradiol is the prime good one. It's what they call E2 estrogen. There's what they call E4 and E16 estrogens. Those are the bad ones. Those are the estrogens, the ones that promote PMS, that promote out of control stimulation of reproductive organs that can lead to breast cancer or ovarian cancer. Those are the ones you don't want. The body clears that out through a process called methylation. It takes a methyl group, attaches to the hormone, says, get out of here. We don't want you anymore.
And a lot of people are not good methylators, right? And so all that means essentially is that you're not able to utilize and get all the good B vitamins from your diet that you need to create these methyl groups to excrete things out. And then you actually need to be going to the bathroom every day. Like these women who talk to me about, I only take a poop twice a week. That's problematic when it comes to excreting toxins of all sorts from our body, you know. So I run the Dutch test on myself at least twice a year, always having Dr. Lee look at it to make sure that we're on the right path with the treatments that we're doing, the supplements, the diet that I'm on, all these things, they have to evolve as these indicators are telling us, things need adjusting.
This is a level of fine tuning, and you're more of a Ferrari than a Chevy pickup truck. So that's what, twice a year is kind of necessary for the level of getting this right. Because when you first came to me, this was all off. You had some ovarian failure and other stuff going on. So it is higher performance tuning. Not everyone needs to do it twice a year, but at least if you're entering into the question of what's going on with my hormones, it's a great test to start with because it shows you the whole pathway, where it's coming from and where it's going. So we can tune those little wrenches and adjust things for those like you, or even the Chevy pickups who are running poorly. So
yeah. And maybe in another day we can talk about how thyroid hormones work into this whole conversation.
Okay.
We'll save that for another one. All right. Anything else you want to touch on with HRT?
Well, there are 1,000 things, but this should open up some ideas in those who are watching this, thinking about it. But again, if you go out in the world and you talk to your typical primary care OBGYN, if you're really lucky, they'll say, yeah, there's something to that, instead of, no, we don't do that. We only do the science. Well, that's the science of 15, 20 years ago. Get current with the regular science. So you will be in the frontier. It may be harder to find the answers that you want and need, but don't give up.
All right.
Let me check.
That was pretty